It's a surgical procedure done to mitigate the variceal bleeding due to portal hypertension. Okay? The most common cause of portal hypertension is cirrhosis and develops as a consequence of increased intrahepatic vascular resistance, causing increased blood flow through the portal system. Now, which part of the liver causes this? This is the hepatic stellate cells in the space of DC, the so-called subendothelial space between the sinusoids and the hepatocytes, which are activated, and they produce collagen that replaces the normal matrix. So the liver starts shrinking. So the subendothelial fibrosis occurs and liver function deteriorates. These activated stellate cells, they are contractile in nature and they are able to regulate the sinusoidal blood flow also. The constant contraction of these activated stellate cells is promoted by their increased susceptibility to vasoconstrictor released called endothelin from the vascular endothelium, and a reduction in vasodilator nitric oxide within the liver. So there is an imbalance between the vasodilating nitric oxide production to vasoconstrictor endothelin production. So there is an upper hand by endothelin. So there is a constant vasoconstriction which threatens to decrease the blood supply all the time. In contrast to it, the intrahepatic levels of nitric oxide concentrations are elevated in the peripheral and splenic circulation, so they become more dilated. This results in systemic and splenic vascular resistance, thus increasing portal blood flow. So this is a major factor in both exacerbating and maintaining portal hypertension. So as a result of these pathological changes, the portal systemic gradient increases and venous collaterals develop in attempt to decompress the portal system. So the collaterals predominantly occur at the gastroesophageal junction and the rectum. So this picture will give you an idea about how a normal liver, these are the hepatocytes, and this is the sinusoid with the endothelial lining here, and between this hepatocytes and the sinusoid, this gap is called the space of DC. And in the space of DC, there are stellate cells which are dormant or quiet during in a normal liver architecture. And there is a Kupffer cells which is mainly phagocytic in nature to absorb the toxins and deactivate them, which is present within the hepatic sinusoids. But once the patient develops a liver injury due to either alcohol or viral infections or nutritional, for any reason, if they have a tendency to develop a cirrhosis, what happens? These quiet stellate cells are getting activated and they multiply and they produce a lot of collagen here in the space of DC. And the space of DC is important because unlike other organs, there are no specific small vascular channels here. These sinusoids are huge blood containing spaces from where the blood has to go to the hepatocytes and take all the ingredients for metabolism like protein, fat, and the carbohydrates. So this space is very important. So when this space gets filled with the matrix, collagen, then what happens? It starts shrinking. So this is the activated stellate cells, deposition of scar matrix, and there is also Kupffer cell activation because it's an inflammatory process. The Kupffer cells, which are supposed to be the protective cells, they are also activated. So the structural change causes 50 to 70%. Results may be because of granuloma, thrombosis, fibrosis, regenerative nodule inflammation. And vascular tone increase occurs up to 30 to 50%. And the Endothelial relaxing factor, that is nitric oxide, is reduced and endothelin is increased. So what happens? There is an increase in hepatic vascular resistance, which leads to portal hypertension, and there is increased portal venous flow also. And the third thing is perpetuation and aggravation of portal hypertension by increased portal venous pressure. So all these things lead to now, by surgical shunting involves end-to-side portal anastomosis or distal splenorenal shunt, and the operative mortality increases with the severity of liver disease, and patients with child's grade C cirrhosis have a very poor prognosis. So we know there are three grades A, B, C, which she described based on the parameters: bilirubin, albumin, ascites, and nutrition, etc. And the shunting is now rarely performed as TRIPS has become more favorable. What is this TRIPS? It is a transjugular intrahepatic portal systemic shunting. This is just like any other shunt that you produce for overcoming an obstruction. This is a more semi-invasive done through the vascular system. So this after this procedure has become much more safer and easy to practice. The operative procedure of doing a laparotomy, opening and then going to the retroperitoneal area and trying to do vascular anastomosis, all that difficult surgical procedures are avoided. So these are the pictures that tell you about it. So here you can see there is the portal system vein. Portal vein is dilated here, and there is a spleen here which also communicates with the portal system that is connected to the renal vein. So this is the IVC. So earlier they were doing a direct communication between the portal vein and the IVC, but later on this is called the distal anastomosis, where you can connect the splenic vein to the renal vein, and this is a distal anastomosis because the length of the vein needed to bring it here close to the origin of the IVC is long. So this is called the distal anastomosis. Then there is a technique called proximal anastomosis, where you can connect it with the left renal vein with the splenic vein coming to the one of the branches of portal system. Then there is a side-to-side anastomosis, where the portal vein is directly connected or a branch of splenic vein is directly connected to the renal vein. So these are the three varieties of splenorenal shunt which are done. And this is a small flow chart which you can use for exam purposes. So preoperative evaluation, history, physical examination and investigation. So what are all the baseline investigations you do? It is full blood count, coagulation profile, LFT, electrolytes, creatinine, and in addition, as a routine, you have to do ECG, echo, and CXR, because these also can be altered or there may be variations in this. Then patient diagnosed with liver disease, risk assessment. So after doing all the history and the evaluation, you can do the risk assessment, and the main risk scoring system used is the child record approved system, CTP system, ABC, and all the points that are there. So based on that, you have the various risk gradings. Then intraoperative management, again there is another short flow chart for you to remember. Think of the monitoring, standard monitoring, and like SpO2, EC, NIBP, and capnography. In addition to that, you can also use invasive monitoring if you anticipate any major blood loss or advanced stages of liver disease. And induction, we can use fentanyl is preferable and Tiva can be used, but all these drugs have to be given in a graded fashion because they are all metabolized in the liver, and the capacity of the liver to handle this is very, very important. And maintenance, you can use inhalational agent like isoflurane, otrolaxin, Epironium with caution, or nowadays we have the atracurium and cisatracurium, which is much more safer and can be used. Then post-operative management, again you have to monitor the liver function, renal function, coagulation profile, sugar levels, because that can vary. It should be closely monitored, preferably done in ICU for at least 24 hours. And particularly in higher risk cases like CTP B and C, pulse BP, SpO2 continuously monitor. Generally, avoid nephrotoxic drugs, and regional anesthesia for pain management can be given provided coagulation profile is normal, and parenteral feeding, in case enteral feeding is not there, we must keep an eye on the nutrition also. Now coming to epidural analgesia in these patients, using them for following major liver resection, there are some safety concerns because of there is a possibility of derangement of coagulation parameters. However, no cases of epidural hematoma have been reported in these cases. So people have been using mid-thoracic or upper thoracic level epidural for post-operative pain relief, even in liver transplantation. So this being a non-transplant surgical procedure, if the coagulation profile is normal, you can use epidural for a post-op pain relief. At the same time, you have to be quite cautious about the use of the dosage of local anesthetic, which also metabolized local anesthetics are also metabolized in the liver. So one has to be very watchful with the dosage that you use. So this is a very short form from the examination angle of writing this question within the time available. Now I will share another PPT on the